everyone. Welcome to this session on finding patterns. So the reason I wanted to do this session is because we have to understand that at the core of medicine, at the core of anything that you diagnose in medicine, lies what lies? Pattern recognition lies. Whenever you see a patient, for example, like let's say when I see an oncology patient, when I see a patient of leukemia, how do I know that he has leukemia? Because I've seen so many patients of leukemia and I've come to recognize that pattern. Oh, he's having fever, he has required one blood transfusion, and he's having a little bit of spots. These three things together itself is telling me, okay, fever probably because the WBC count is low. The blood transfusion tells me there has been anemia, and these spots are the petechial spots because of thrombocytopenia. I pick this up as an oncologist, I recognize this pattern, and I'm able to make a clinical diagnosis that this might be pancytopenia secondary to leukemia, maybe aplastic anemia. Then I look at the child. Any good doctor, any good clinician, any good diagnostician, we all love house. What they were doing, they were just looking for patterns. Right? At the core of medicine, when you are diagnosing and when you are in a clinic or wherever you are doing nothing but pattern recognition. These 3-4 things are occurring together. This fits into this pattern. Cream, Kawasaki disease, conjunctivitis, rash, extremities problem, adenopathy. These things fit together. That is Kawasaki disease. Take any other, SLE, malar rash with mouth ulcers, with photosensitivity. You find that pattern, that is SLE. At the core, anything in medicine is pattern recognition. We need to be able to find patterns as far as your PYQs are also concerned, and as far as concepts also are concerned. A lot of people tell me, and a lot of messages come, sir, I study a lot, but I'm not able to remember stuff. If we find patterns and stuff, the act of remembering, the act of recall also becomes easier. And that's the goal of the session. I'll give an example. For example, let's say this is a random number, someone's number, I don't know. This is a random number. Please don't call this. It's a random number that I just wrote it down. 9910062690. If you try to remember it like this, random bunch of 10 numbers, 10 letters. But if I ask you to remember this number, for example, you'll be easily able to remember it. 9876543210. Well, this one, as compared to this one, obviously, this one as compared to this one, obviously is a little trickier to remember. But if I ask you to remember it, you will try to find patterns into it. You will chunk stuff up. You will probably like, okay, it is 99, then 100, then 62, and the boys will be like 62 followed by 69 and then 0. So you might make some patterns, you might make some chunks like that. There's something which we do intuitively when it comes to other stuff. Let's start to do it a little intuitively as far as your PYQs are concerned, as far as your previous topics are concerned, as far as concepts in general are concerned. And that is one particular concept that I'll discuss today. We'll see how that one single concept and that pattern of that concept is being repeated in multiple topics, and how questions are being asked from multiple topics from that. And you don't need to remember each thing individually. Everything will be combined together with that particular pattern, with that particular dictum, and you'll be able to solve multiple questions on the go. Let's start. Okay, to tell you the pattern that I'm going to tell you, this is a dictum which was given to me in my pediatric emergency, and this will help you remember a lot of stuff, a lot of concepts as far as, and a lot of topics as far as pediatrics is concerned. And the dictum was very simple. The only thing worse if it's in an emergency, a lot of children come, they're obviously cranky, right? They're crying, right? In pediatric emergency or anytime in pediatrics, the only thing worse than a crying child is a child who is not crying, is a child who is not crying. The only thing worse than a crying child is a child who is not crying. This is what my senior residents, when I was doing my residency in pediatrics, used to say to me. What is the concept and rationale behind this dictum? All right, let's understand that. See, when a child has come to an emergency, he's cranky, he's irritable, he's crying. At least you know he's alive. If a child is not crying and has come to you in emergency, there's a good possibility child is already dead or the child is on the verge of dying. And this is something which is repeated throughout multiple illnesses as far as pediatrics is concerned, multiple classifications as far as pediatrics is concerned. Initially, when the body is faced with an insult, when a pediatric body, when a child is faced with an insult, child will become cranky, child will become irritable, he'll cry. But when the disease becomes more severe, now he's on the verge of death, he'll become lethargic, comatose, and will not respond. This is a simple pattern. Everywhere in the classification, you'll understand this pattern is getting repeated again and again and again in multiple things throughout pediatrics. Initially, whenever the disease is less severe, whenever the mortality is going to be lesser, when the disease prognosis is going to be better, you'll have an irritable child. And as soon as it turns into something severe, something more serious, something which has higher mortality, child will be lethargic, comatose, will not feed, he'll be on the deathbed almost on the deathbed. Let's see how this is getting repeated. This thing is getting repeated, this pattern is getting repeated in multiple times across multiple concepts, which you might think are not related, but are. Okay, let's first start with a very simple core pediatrics topic, Kwashiorkor versus marasmus. So we all know why Kwashiorkor occurs. Kwashiorkor is essentially occurring because there is visceral protein loss. There is what? There is visceral protein. What is visceral protein? Protein which is basically there in albumin, neurotransmitters, in your enzyme. Well, why does marasmus occur? Marasmus occurs because of somatic protein loss, that is muscle protein loss, and it occurs because of calorie deficit in diet. It occurs because of calorie deficit in diet. Now, think logically. In Kwashiorkor, visceral protein is lost. Albumin is lost, your neurotransmitters are getting lost. While in marasmus, only your muscles are getting lost. The protein in the muscle is getting lost. Which is more important for your survival? Of course, your visceral protein, the albumin, the neurotransmitters, they are much more important for survival. And that's why, what's going to be, which disease will have a much worse prognosis? Kwashiorkor will have a much worse prognosis. The prognosis is going to be much poor as far as Kwashiorkor is concerned, while in marasmus, the prognosis is going to be good. Better as compared to Kwashiorkor. In Kwashiorkor, how will the child look like? He'll be very lethargic. General condition of the child, he'll be lethargic. He'll be comatose. And because he has lost albumin, obviously he'll be edematous. Well, as far as marasmus is concerned, what's going to happen in marasmus? The child has lost muscle protein, but he still has the visceral protein, he still has the neurotransmitters. So general condition wise, because he's not taking any food, now he's irritable. He wants food. That's why child in marasmus is irritable. Because he has lost muscle protein, there'll be a baggy pant appearance. Because if you have lost muscle protein from your gluteus maximus, the skin over the gluteus maximus over your buttock will hang. That will cause a baggy pant appearance. And of course, if you're lethargic, you will have no appetite. Well, in marasmus, the appetite will be good. In fact, they say they have a very high appetite. They have a voracious appetite. Appetite is increased. This is a very simple concept. Marasmus is a better disease. Why? Because they have better appetite. They can take food. And they are irritable. The only thing worse than a crying child. Marasmus is a child who's crying. Marasmus is a child who's irritable. He's taking food. He wants more food. He's not again getting food. The only thing worse than a crying child is a child who's not crying. And which child is not crying? Kwashiorkor child is not crying. Why is he not crying? He has lost all the neurotransmitters. He has lost albumin. As a result, he's very lethargic, comatose, has edema, has lost all the appetite. And as a result, the prognosis is poor as far as Kwashiorkor is concerned, while the prognosis, like I said, is better as far as marasmus is concerned. Even in the pictures that we look at, look here. Kwashiorkor child, he will always be shown with a sad face. While as far as the marasmus child is concerned, he'll always be shown crying. The only thing worse than a crying child is a child who is not crying. So Kwashiorkor always has a worse prognosis. In general, no appetite, no activity, and hence a lot of lethargy. The only thing worse than a crying child is a child who is not crying. Let's come to another thing. Let's come to SAM. Now, SAM is classified into two categories: complicated and uncomplicated SAM. As far as uncomplicated SAM is concerned, obviously uncomplicated SAM will have better prognosis. In uncomplicated SAM, there are no medical complications because the child is not lethargic. He is crying. He has good appetite. Why he has good appetite? Because the irritability is there. He wants food. The child wants food and there is no edema. While in complicated SAM child is lethargic. Again, there will be complications. There will be edema, and since he is lethargic, appetite is poor. So again, SAM is again divided into complicated and uncomplicated, again on the same dictum. The only thing worse than a crying child is a child who is not crying. So complicated SAM, you have a lethargic child. And obviously if you have lethargy, the appetite is going to be poor. While uncomplicated SAM, good appetite, and obviously there is no lethargy. In fact, child might be irritable. We come to dehydration. The dehydration classification, we all know dehydration is classified into no, some, and severe. Again, the same dictum is going to apply. The only thing worse than a crying child is a child who is not crying. Look here. Consciousness. So in no dehydration, everything is going to be normal. So I'm just going to write that. Consciousness, thirst, skin pinch, and eyes, everything is going to be normal as far as no dehydration is concerned. In some dehydration, what will happen to consciousness? Crying child, irritability. Severe dehydration, lethargy. Thirst. He's irritable. In some dehydration, child is irritable. Why? He wants water. He has lost some water. So there is increased thirst. There is increased thirst. In severe dehydration, child is lethargic. He is unable to drink water. He is unable to drink water. Now, skin pinch is delayed in some dehydration. Skin pinch is very delayed in severe dehydration. Eyes are sunken in some dehydration. Eyes are very sunken as far as severe dehydration is concerned. Alright, since we are talking about dehydration, I'll just give a brief introduction about the management of dehydration. Plan A we use for no dehydration, where we give ORS 10 ml per kg with each loose stool. Plan B we give ORS 75 ml per kg over 4 hours. But plan C we give for, plan B we give for some dehydration, and plan C we give for severe dehydration. Remember, in severe dehydration, child is lethargic. He's unable to drink. You can't give him ORS. How will he drink it? You have to give IV fluids. You have to give IV fluids. How much? You give 100 ml per kg, either over 3 hours or over 6 hours, depending upon the age of the child. Child is more than 1 year. Child is more than 1 year. You give it over 3 hours. Child is less than 1 year. You give it over 6 hours. This same concept, if you're lethargic, you can't give oral feeds. You have to give IV feeds and IV fluids in general. This concept again will come somewhere else. We'll come to that again. If we come to the pneumonia classification, again the same dictum is going to apply. Let's see how. Again the same dictum is going to apply. The only thing worse than a crying child is the child who is not crying. So pneumonia also is classified into 3 categories: no pneumonia, pneumonia and severe pneumonia. No pneumonia is basically nothing. There's only cough and cold. There is no feature which is suggestive of pneumonia or severe pneumonia. No feature suggestive of pneumonia or severe pneumonia. Treatment, obviously nothing is required. We just give soothing measures. If there is no pneumonia, why do you need to give anything? There is no role of any antibiotics here. There is no role of any antibiotics here. Now, pneumonia, the less severe one. The only thing worse than a crying child is a child who is not crying. So in pneumonia, the child will cry. If the child is crying, what's going to happen? Crying obviously means a lot of sympathetic activity. So the respiratory rate, because of the sympathetic activity, will increase. Pneumonia is of 2 types according to INICET. You can have a fast breathing pneumonia. You can have a fast breathing pneumonia, or you can have a chest indrawing pneumonia. You can have a chest indrawing pneumonia. As far as treatment is concerned, here we give oral antibiotics. Here we give oral antibiotics for 5 days and follow up in 2 days. Warn the mother of the danger signs. Warn the mother of the danger signs. Fast breathing has different cutoffs. The goal of the session is not to teach you these topics, but to understand that in all these seemingly non-related topics, a single broad concept, a single pattern is getting repeated again and again, so that it helps you in remembering it when it actually comes to your exam. Okay. As far as severe pneumonia is concerned, severe pneumonia is said when there is stridor in a calm child. When there is stridor in a calm child. Why is the child calm? Child is not actually calm. Child is actually lethargic. Child is not actually calm. Child is actually lethargic. In fact, we say if there is very severe disease, if you have any one of the following, if the child is lethargic, obviously if the child is lethargic, there is going to be what? There is going to be poor feeding, or there is high-grade fever, or there is high-grade fever, or there is a decrease in SpO2, or the child is having convulsions, As far as treatment of severe pneumonia is concerned, or very severe disease is concerned, again, remember, I told you, right? Anytime you have lethargy, you can't give something orally. In some dehydration, we were giving ORS, while in severe dehydration, we were giving IV fluids. Same concept is valid here. In pneumonia, you will give antibiotics, oral antibiotics. But in severe pneumonia, now you can't give oral antibiotics. You have to give IV antibiotics. And because IMNCI is made from a sub-center or a PHC point of view, you can't manage severe pneumonia at a primary health center. You have to refer. So you will refer after the first dose of IV antibiotic. After the first dose of IV antibiotic. That's as far as IMNCI is concerned. Next we come to HI. Even HI will follow this pattern. We all know staging of HI is very important. Standard and standard staging, stage 1, 2 and 3. Stage 1, 2 and 3. Now the only thing that you need to remember in staging of HI, and everything else will become clear, is the autonomic involvement. Crying child, not crying child. That's it. Initially you will have a crying child, then you will have a child who is not crying. That's a dictum, right? The only thing worse than a crying child is a child who is not crying. Let's see how it manifests itself in the staging of HI. So HI is divided into 3 stages, stage 1, 2 and 3. The only thing, the core thing that you need to know is this autonomic involvement. In stage 1 HI, you have crying child. You will have sympathetic overactivity. You will have sympathetic overactivity. Stage 2, non-crying child. You will have a parasympathetic overactivity. You will have a parasympathetic overactivity. While as far as stage 3 is concerned, in stage 3 the damage is so severe, child is essentially brain dead. There will be no activity. There will be no activity or zero activities. Child is essentially, in some sense, brain dead. Right? The only thing worse than a crying child is a child who is not crying. Sympathetic overactivity, parasympathetic overactivity, no activity. If you just remember this, everything in staging of HI becomes extremely easy. Now look here. What will happen to pupil size in stage 1? Sympathetic overactivity. Pupil size will increase. What will happen in stage 2? Pupil size will decrease. You will have meiosis. In stage 3, it can be anything. There is brain is essentially dead. It can be anything. Variable. Same for heart rate. Stage 1, what will happen to heart rate? Heart rate will increase. What will happen in stage 2? Heart rate will decrease because of parasympathetic activity. What will happen in stage 3? Anything can happen. It can be variable. If I come to consciousness, again, crying child, non-crying child. Initially, child is, in stage 1, child is irritable. In stage 2, child is lethargic. And in stage 3, brain dead. High, low, nothing. This is the pattern of staging of HI. High, sympathetic overactivity, low, nothing. Stage 3 is basically a brain dead kid. So in stage 3, consciousness, child will be comatose. He will be having coma. Reflexes, again, high, low, nothing. So in reflexes will be exaggerated in stage 1. They will be depressed in stage 2. And they will be absent in stage 3. Seizures. See, stage 1 is not severe enough to cause seizures. So seizures don't occur here. In stage 2, the severity has increased. So seizures will occur. And in stage 3 HI, now the brain is dead. If you have a brain dead child, how will the seizures occur? Again, seizures are not there. Clinically evident seizures, in fact, are not there. If I come to posture, EEG and prognosis, let's come to that as well. Posture, stage 1, normal posture. Let's go back to GCS also. If you will remember a little bit of GCS, you will remember that abnormal flexion is considered better than abnormal extension. In stage 2 HI, you will have abnormal flexion. In stage 3, you will have abnormal extension. EEG is going to be normal in stage 1 HI. EEG, there will be what? High, low. There will be low voltage complexes. In stage 2 HI, as far as stage 3 HI is concerned, brain dead. So you will have isoelectric EEG. You will have an isoelectric EEG like this. Brain dead. In essence, you are brain dead. Prognosis, obviously, 99% cases are normal in stage 1. 80% cases are normal in stage 2. Here, 50% end up being dead in stage 3. Or 50% have a long-term poor prognosis later in life. So even in HI, that same concept is valid. 1, 2 and 3. You don't need to memorize the entire table. The only thing you need to know is autonomic involvement. Stage 1, sympathetic overactivity. Stage 2, parasympathetic overactivity. Stage 3, brain dead, no activity. Everything will be high in stage 1, everything will be low in stage 2, and there will be nothing in stage 3. That's it. If you try to rote memorize all this stuff, obviously it will get tougher. On the exam day, you might forget. But if you just remember this basic concept, if you just remember this dictum, the only thing worse than a crying child is a child who is not crying. Alright, lethargy is always more severe as compared to irritability. That's all you need to know. Stage 1 will always have irritability. The initial stages of diseases will always have irritability. Later followed by lethargy, and in here, in case of another stage 3, absolutely zero activity, a brain dead kid in a sense. That's it. That's all you need to know. Similarly, as far as morose is concerned, sometimes they have asked this question also. Where will you see exaggerated morose? Exaggerated reflexes are seen in stage 1 HI. They are seen in stage 1 HI. Why exaggerated reflexes? Because there is sympathetic overactivity. You also have sympathetic overactivity in hypoglycemia. So hypoglycemia, glucose goes down, adre and noradre goes up. to increase the glucose. So hypoglycemia can also have exaggerated morose. Same, absent morose will be seen in HI stage 3. Absent moro will be seen in HI stage 3. Simple. Sometimes downs can also have absent morose. These are seemingly unrelated topics, but if you just remember the first dictum, remember the first pattern that I talked about, the only thing worse than a crying child is a child who's not crying. Lethargy will come afterwards. Initially comes irritability. When you are a little sick, you are irritable. When you are more sick, when you are on deathbed, you are lethargic and you are comatose. And you won't feed. The appetite will be lost. If you just remember this dictum, so many concepts of pediatrics in one go. You don't need to rote memorize it. This is a basic concept. You understood this concept. You understood this pattern. And 7-8 topics in pediatrics are covered. Let's discuss some PYQs. And see how this pattern keeps on getting repeated again and again in PYQs as well. It gets repeated in PYQs as well. Simple one. Seizures are seen in which stage of HI? So I told you, stage 1 is not severe enough to cause seizures. Stage 2, you have seizures. And in stage 3, you are brain dead. So how will you have seizures? So answer here is going to be stage 2 HI. Answer here will be stage 2 HI. So this is a previous year question, both as far as NEET and AIIMS is concerned. Let's see next question. This is a recent FMG question. A 2-year-old child has come to you with mid-upper arm circumference of 110 mm. Okay. He has good appetite. Appetite is good. Child has. See, mid-upper arm circumference of 110 mm. 110 mm is basically 11 centimeter. And we all know anytime mid-upper arm circumference less than 11.5 centimeter, we say child is suffering from, we say child has what? SAM. Now we just discussed SAM has two types, complicated and uncomplicated. Complicated means more severe. Lethargy will be there, hence appetite will be poor. While in this question, they are very clearly mentioning to you, they are very clearly mentioning child has good appetite. So this cannot be complicated SAM, this will be uncomplicated SAM. Hence the answer is option B, uncomplicated SAM. Answer is option B, uncomplicated SAM. Let's see next question. This is a AIIMS or INICET question. A child has presented you with cough and cold. Child is lethargic, has high grade fever with respiratory rate is 52 per minute. What is the next step? They have given lethargy. Anytime you have lethargy, it automatically becomes severe pneumonia. And in severe pneumonia, we discussed this in dehydration also. We discussed this that in severe dehydration, child is lethargic, you have to give IV fluids. In severe pneumonia, you can't give oral antibiotic, you have to give IV antibiotics. And because it's a primary health center, you can't manage there, you have to refer. So since this child is lethargic, he's having cough and cold, this automatically becomes severe pneumonia. You will refer after giving the first dose of IV antibiotic. So answer will be referral to a higher center after the first dose of IV antibiotics. Let's see another question of AIIMS and INICET. Which of the following holds true for some dehydration? So some and severe, I told you one major difference is some is irritable child. He wants more water. He is irritable because he is not getting any water. Severe dehydration, only thing worse than a crying child, non-crying child. Child is lethargic. If he is lethargic, he can't take water. He is unable to drink water. Alright, let's look at the options once. Let's just look at one option. Let's look at option 2. Option 2 says mental state is lethargic. So option 2 is incorrect. It doesn't hold true. So anything which has option 2, B and D, I can immediately rule it out. Now let's look at the other option, 1, 3, 5, 1, 3, 4, 5. So I just need to look at option 4. Option 4, sunken eyes present, yes. Yes, sunken eyes are present in some dehydration. Eyes are very sunken as far as severe dehydration is concerned. So we have our answer. Answer here will be option C, 1, 3, 4 and 5. And I didn't even need to look at all the 5 options. Just by looking at this one, I could easily rule out 2 options. The main thing they wanted you to know, whether you know child is lethargic or not in some dehydration. Some dehydration, little less severity, irritable child, severe dehydration, more severity. The only thing worse than a crying child who is not crying. Let's look at another question. Which of the following is not seen in marasmus? Marasmus, better prognosis. You only lose somatic protein. You will be irritable, not lethargic. So lethargy is not seen in marasmus. Exaggerated maro is seen in. Exaggerated reflexes, more sympathetic overactivity, irritability, stage 1 HI, or if you have sympathetic overactivity, which can be there in hypoglycemia. So answer here will be hypoglycemia. Let's look at another question. Which of the following is seen in some dehydration? Lethargy, increased thirst, normal urine output, alert child. We know lethargy is not seen, it's seen in severe. Normal urine output is not there. You have some decrease in urine output if you are dehydrated. So this is incorrect, and you won't have an alert child, you will have an irritable child. And when you are irritable, you want more water. The source is increased. The answer will be option B. All these are PYQs. They may look different, but if you remember the first dictum I told you and the first pattern I told you, if you find these patterns, and these patterns exist throughout multiple subjects. These patterns do exist throughout multiple subjects. It will become easier to remember these classifications. It will become easier to remember these facts, and it will be easier to apply these facts when MCQs comes. MCQs and PYQs, they are also pattern recognition. The people who get better ranks, they just have better pattern recognition than the people who get a slightly lesser rank. Become better at this pattern recognition and you will get what you desire. That's it from my side today. Thank you and have a nice day, and wish you all the best. We'll continue this series in the coming weeks. Please keep working hard. Work hard. November INICET is very doable. And I wish you, all of you, I will say not everyone can get a top 100 rank, but those who prepare sincerely, I wish every single one of you gets a top 100 rank. Thank you.